expanding access to new tools for TB screening and diagnosis, experience using digital X-ray and CAD4TB in Uganda. Uganda is among the 30 high-burden TB and TB-HIV countries globally, and we are among the 20 countries that contribute 80% of people missing with tuberculosis. Our estimated incidence is close to 200 per 100,000 population. The treatment coverage as per 2021 was 76, although this year we moved to 82. The WHO, the revised guidelines of systematic TB screening recommended use of X-ray and computer-aided detection CAD for TB screening and triage at health facilities and in communities. However, in Uganda, access to these technologies remains limited. We introduced digital X-ray systems in 2020, and since then we have acquired 12 of them with CAD, including additional 2 mobile clinics, which were fitted with the X-ray and CAD and GeneXpert machine. They are deployed at health facilities for TB screening, and also we conduct outreaches in hotspots. Next slide. We, as part of making sure that the implementation goes on smoothly, we conducted user training for radiographers and clinicians to use the systems. We also conduct on-site mentorship and training of health workers on the use of the X-ray in TB screening and triage. We developed a guide for people to follow while applying these new tools. And we do coordination meetings with the districts and partners to see how the implementation is going. So what do we do at facilities to ensure that the X-ray screening happens? So we, where the at the 12 health facilities where the machines are placed at the health facility, we do seek from patients attending OPD symptom screening, but also offer the X-ray service among those that present with the symptoms, and also concentrate on those attendees who fall in the high risk categories that we have identified as contacts, people living with HIV, health workers, prisoners, and others. Then those who have suggestive X-ray films and the CAD score of more than 50 are requested to provide them sputum, and we do send this for the lab diagnosis. And confirmed cases are initiated on treatment at these facilities. Next slide. At community level, with the mobile clinics, but also before the mobile clinics with the mobile digital X-ray machines, we map hotspots and conduct mobilization of communities together with the districts, and then do the screening event. And the process of identifying presumptives is similar to what we do at the health facilities. Now, the mobile clinics have brought a new addition in terms of improving care and quality of services, because the GeneXpert machines that we have put in these clinics help us to do same-day diagnosis and treatment initiation. Next slide. So monitoring of our work, we initially had on the paper-based systems. Thanks to the Delft team, they have come up with the SAM app, which we are trying to incorporate in our implementation to see how we can get the data at central level. Next slide. So what have we done with these tools? So we see that using the digital technology, we see the screening yielding more cases among presumptive cases, with the diagnostic yield at close to 5%, which is not the case with the routine implementation of programming and symptom screen. Next slide. So this is using portable digital X-ray equipment. Like I've said, the yield is much bigger among the presumptive cases. In this case, you see among those screened that were presumptive, 14.4% of them actually had confirmed TB, which is a very high yield compared to other ways of doing the screening and diagnosis. Next slide. For community screening, new application in the digital technologies expansion and scale up. Still, the yield remains big, but we have also been able to get some drug-resistant TB cases in this in the community screening, who would not have been identified if we did not go to these communities. Next slide. So what have we learned? We have learned that congregate settings provide a big and good opportunity for improving TB yield. And this could be related to what people do and where they are, and other vulnerability factors, their access to care. There is a high number of TB cases observed in some hotspots, which is helping us to better program and understand how to support these such hotspots to reduce the TB transmission significantly. Community mobilization is key. If we don't have mobilization, the people will not come for the screening activity. Integrating screening approaches is key also to improve uptake. The X-ray being able to detect also other things other than just TB. Good outcomes with CAD4TB. And then use of mobile digital X-ray can be done using clinicians other than depending on radiographers. Next slide. So among the challenges that we have seen and what we think could help to improve, delayed gene expert results. When we go to the communities and the gene expert is not on site, definitely the return of results takes a while, and this causes delays in treatment initiation among those that have confirmed TB. Inadequate mobilization of communities results in poor performance of the screening activity. And then communities demand for other services, including screening for other conditions, which I think is okay, that we integrate the screening to be able to be more people-centered and more acceptable to communities. Next slide. Downtime. We sometimes get the machines broken down. The process of getting the replacements of this equipment also takes some time. I'm glad from the presentation that happened, there are plans to make such things rectified. The report is not there with these systems. We don't do printing, so patients have nothing to go with or clinicians to refer to other than what we tell them. the infrastructure, the road network, especially for the mobile clinics, which can only reach certain places and not all the inner communities. Protective gear, we have one per machine, and we think we may need more than that. The service contracts for the parts of the clinic also needs to be worked on. Next slide. I would like to acknowledge our ministry and the teams at the National TB Process Program that have provided the environment for us to scale up these new technologies, to reach out to the communities for screening. Our donors, USAID, the Stop TB Partnership, the Global Fund, WHO, and all our donors that have supported the scale up. We want to thank you, the implementing partners that support the movement of the digital machines. Delft, you have given us an opportunity to learn, and you have been with us. We want to thank you for the support. There are delays, but at least you respond whenever we reach out to you. And then the local agent that is with us in the country, RIMA, East Africa. Thank you for this opportunity. Over.